Skagdash Ananam Chigig, Mikah Carlos, Chunakima Amjad. Good day, everybody. My name is Mikah Carlos. I come from the Salt River P. Maricopa Indian community, where I also serve as a council member. I'm also honored to serve as a board member for the National Indian Health Board representing the Phoenix area. On behalf of the National Indian Health Board and the 575 federally recognized tribal nations we serve, we thank you for the opportunity to provide testimony in support of H.R. 8658, the IHS Emergency Claims Parity Act. And thank you, Congressman Kennedy, for introducing this bill. The NIHB strongly supports this legislation because it provides a straightforward and common sense fix that will help ensure tribal patients can access emergency medical care without being burdened by unrealistic and administrative requirements during moments of crisis. We appreciate the subcommittee's leadership on this issue and urge swift advancement of this legislation. The federal government maintains a unique legal obligation to provide health care for all American Indian and Alaska Natives, grounded in treaties, statutes, U.S. Supreme Court decisions, and the federal trust responsibility. The Indian Health Service-funded hospitals and health clinics serve approximately 3.2 million people, many in rural and remote areas. However, there are limitations to what the Indian health system is able to provide. The Purchase Preferred Care Program allows IHS to purchase health services from non-IHS providers when care is not reasonably accessible or available within IHS or tribal health systems. For many tribal communities, especially in emergency situations, this program is essential to receiving life-saving care. In Arizona, specifically even the Phoenix area sometimes, the nearest IHS emergency care center is upwards to 1 to 2 hours away, with the nearest non-IHS facility being a 10-minute drive. When you're in an emergency, you're not thinking about which medical facility will be easier to deal with billing, but more focused on immediate care. Currently, the most IHS beneficiaries must notify the PRC program within 72 hours of receiving emergency care at a non-IHS facility in order for that care to be covered by IHS. That 72-hour clock begins the moment care is first received. In practice, this means that even an unconscious patient may lose coverage if notification is not made in time. A few weeks after I turned 18, I fainted on the side of the road waiting for the bus to school. Thankfully, bystanders stopped and called 911, but due to the nature of the emergency I was having, their concern was getting me to the nearest hospital, which happened to be a non-IHS facility. During that emergency, I never had to navigate the administrative side of the medical system. I was focused on figuring out what had happened and if I was going to school the next day. I was not thinking about the paperwork. I did not know that there was a ticking timeline for me to notify IHS that I had been seen. So when I submitted my claims weeks later, they were denied. In fact, I was told they would not even be considered because they were outside the 72-hour window. That is how at the age of 18, before I had even graduated high school, I was thousands of dollars in medical debt. It is unconscionable to think that we would saddle our youth, our adults, anyone in our communities with a financial burden on top of their health emergency, which is why extending the notification window from 72 hours to 15 days is so important and long overdue. Emergency medical events are often chaotic, traumatic, and overwhelming. Patients may be hospitalized for days or weeks, transferred between facilities, or recovering from surgery, sedation, or intensive treatment. Families should be focused on recovery of their loved ones, not on paperwork or filing an emergency claim. The expectation that patients or their families should have to simultaneously focus on care and the PRC requirements or face massive medical debt is massively overburdensome and unrealistic. Yet under the current system, if the 72-hour requirement is not met, claims may be denied, even when the care was medically necessary or life-saving. Tribal patients can then receive bills from hospitals, providers, and debt collectors for services they believed would be covered. Families can face damaged credit, financial hardship, and lasting stress from medical emergencies that were entirely outside of their control. These denials often occur not because patients acted irresponsibly, but because the system itself is difficult to navigate. Many patients are unaware of the 72-hour rule. Hospitals and outside providers may not understand PRC requirements, and communication delays between providers and IHS can make the timeline nearly impossible to meet. H.R. 8658 would correct that imbalance. Extending the notification window to 15 days would reduce unnecessary claim denials, improve communication between providers and IHS, and give patients and families time to stabilize before addressing administrative requirements. Most importantly, it would help ensure that access to emergency care is not undermined by unrealistic deadlines. Ultimately, H.R. 8658 will help strengthen trust in the Indian health system, reduce avoidable medical debt, and better ensure that these tribal citizens receive the care that is needed when they need it most. We urge you to advance this legislation, and thank you again for the opportunity to testify today. I look forward to answering any questions.